Hello and welcome everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at Community Health Center of Franklin County for hosting today's session, What to Do with Anal Dysplasia with Dr. Scott Nelson. Dr. Nelson is a practicing general colon and rectal surgeon at Asante Three Rivers Medical Center in Grand Pass, Oregon. He is currently serving as Chief of Staff and Medical Director for the Asante Physician Partners 15 specialty clinics. He's been in practice for 15 years, and we're just so very thankful to have him as a MAVEN Project volunteer. So Dr. Nelson, when you're ready, please begin.
Great. Thank you. It's very nice to be here with all of you. Thank you for the invitation to speak on what can be, I think, a very confusing topic of anal dysplasia. And so let's jump right in. Again, if you have any questions, I'm very happy to interrupt and answer those. So you can put those in the chat or raise your hand and we'll try to get all of those discussed today. So let me make sure we've got. There we go. So I don't have any disclosures. I don't receive any financial reimbursement for our talk today or for anything else that I do outside of work. And MAVEN is accredited with the Continuing Medical Education Council. So you, as we just heard, can get some CME credit from this. Well, let's start out today by just talking about what is AIN, or anal intraepithelial neoplasia. And this is something that I think many of you apparently are coming across, and it can be a confusing topic at times. So, but AIN is the precursor for anal cancer, very much like colon polyps are the precursor for colon cancer or rectal cancer. AIN can lead to anal cancer, and it is directly linked to, in most cases, the HPV virus. And so we'll talk a little bit about HPV today, but the serotype 16 and 18 are associated with the majority of this disease that progresses from AIN to anal cancer. AIN is graded in a graduated form from 1 to 3. And it really depends on how the cells look under the microscope, and we're not going to get into any of those details today. But it is important to have an understanding of what type of AIN from a grading perspective we're dealing with, because that does portend to a greater potential for malignant transformation. One key item that I hope you'll remember as we talk about this is that AIN progresses to invasive squamous cell carcinoma about 10% in about 10% of cases. And so I want you to keep that in mind as we talk today about this topic and why AIN is a little bit challenging and what to do about it. So just to kind of start off, the terminology historically has also been a little challenging. And so there were many terms that we used to call anal dysplasia. I think Bowen's disease was probably the most common. If you've been in practice for a long time, you probably remember hearing Bowen's disease. But today the terminology has changed a lot. And so we've tried to simplify it down. And so on a pathology report, you will probably see something like low-grade squamous intraepithelial lesions, or AIN, and an LSIL is equivalent to an AIN1. And then there's also high-grade dysplasia, and that's HSIL, and that corresponds to AIN2 or 3. And so I don't know how your pathologists typically do this, but that is just something to keep in mind, that the grading system, the terminology really has shifted to AIN in particular, and understanding the different grades is going to be important as we talk about this today. So let's just talk a little bit about the incidence of and prevalence of HPV. So it's estimated that about 79, 80 million Americans have HPV. And so that's a lot of people. And 90% of HPV infections don't demonstrate any signs or symptoms, which can make this problematic as we talk about what do we do with this disease when we find it. There's over 180 known serotypes of the virus, and 30 of them are thought to infect the anal genital tracts. And we subtype or categorize these different subtypes of the virus into high or low risk depending on their oncologic potential. And again, we've just talked about some of them, HPV serotype 16 and 18, 34 and 35. Those seem to be the most typically involved with more aggressive cancer formation versus some of the others. But again, about 10% of AIN3 will convert into anal cancer within 5 years if left untreated. And that is really variable depending on the type of patient that you have. And we'll talk a little bit about the risk factors that individuals can have that would increase their chances of this malignant transformation. HPV, though, can lead to many different types of cancers. And so I've just listed these here. There's cervical, anal, vaginal, vulvar, penile, and oropharyngeal cancers. And you can see how often they're associated with HPV. And about 90% of all anal cancers are associated with HPV. Anal cancer is the 24th most common cancer in the United States. And I think this is important just to put into perspective. We just talked about how almost 80 million Americans have been infected with HPV. And yet, if you look at this graph in 2023, there was almost 10,000 cancers. And so if you just do the math, very few people actually progress from an HPV infection to anal cancer. And so that makes it challenging as we talk about what do we do with this, because really the risk of developing anal cancer from an HPV infection is extremely low in most cases. So the average age of diagnosis is about 55, and it seems to affect men and women equally, but maybe a little bit more on the men's side, and we'll talk about that as well. So as we talked about, there's different types of HPV serotypes, and some of them are low risk and some are high risk. The low risk serotypes are 6 and 11, and these seem to be more associated with AIN1. That's the low grade dysplasia. We know that about 3% of people with HPV 6 will progress to cancer, but we also know that most of them have multiple different serotypes that are involved that may be a contributing factor. And so AIN1 is much more prevalent, it seems, in our populations, but again, it has the lowest malignant transformation. And so most of these patients will just simply need some local treatment and surveillance, and we'll talk a little bit about what that looks like in a few minutes. The higher risk HPVs, though, are serotype 16 and 18, and these seem to be associated with AIN2 or 3, the higher grade dysplasias. And again, it's estimated that about 80 to 90% of all anal cancers come from these various subtypes. I think as we talk about HPV, though, we understand that there's a high risk and a low risk serotype of the virus, but there's also high risk and low risk features for our patients. And so we're going to try to marry those today as we talk about this. But the reality is that in individuals who have a number of sexual partners, or they have a previous history of active STDs or warts, if they participate in anal receptive intercourse, if there's a history of cervical or vulvar cancer, these individuals obviously have HPV, but they're also at higher risk for developing the more aggressive serotype 16 and 18. The other risk factors that can be seen in patients really center around immunosuppression. I think that the body's immune system, for the most part, does really well at controlling HPV infections, and we see that just based on the numbers. You have 80 million people with HPV, and yet very few actually go on to develop cancer. But in individuals who are immunosuppressed, and this would be HIV or us suppressing their immune system because of various diseases, we do see that portends to a much more aggressive type of response from the HPV virus that can lead to cancer. And so those are things that we need to consider as we're talking about who do we need to watch more closely. So again, we've got, just as you are sitting with a patient, and you're thinking about what do I do, the first step really is to put them in a risk category. And high risk individuals are those who are HIV positive, and that's even if they're well controlled. Men who have sex with men and those who are immunocompromised, they kind of form their own high-risk subgroup, and those individuals probably need to be dealt with a little differently than individuals in a low-risk subgroup. So those are those individuals who are immunocompetent, who are HIV negative, they don't have IBD, and there's no history of cervical or vaginal cancer. So we do try to separate out the risk that an individual has in the development of anal cancer. And obviously, the group here on the left side is going to be ones that you're going to be much more concerned with than the others. And just to demonstrate this, so here's kind of some studies that have been looked at for HIV positive patients. And again, these are even those that are well controlled. You know, the rate of anal cancer is 30 to 100 times higher than in the general population. And while that risk is low, you know, these individuals just sit in a whole new risk group. And it's estimated that 72 to 90% of HIV patients are infected with HPV. 90% of them have the high risk subtypes of the HPV virus. And in HIV positive patients, 80% of anal cancers occur in men who have sex with men. So again, HIV positivity, anal receptive intercourse, these are the kind of the high risk factors that we see, as well as those who have been immunosuppressed for other reasons. Lastly, on the bottom there, a Lancet study from 2012 found that the progression rate is 1 in 600 per year for HIV positive men who have sex with men, versus 1 in 4,000 per year for HIV negative men, HIV negative individuals. And if they're a man, they still may have anal receptive intercourse, but it's that combination of HIV positivity and men who have sex with men or anal receptive intercourse that really seems to put them at the highest risk category for the development of AIN and subsequent progression to cancer. So I think when we got the request to speak on this, the topic really was, what do we do? This is a confusing subject. And so I just wanted to put these two statements up for you. The reason why it's confusing is because it is confusing. It's confusing for everybody. There isn't really great guidelines that have been established. So this came out in 2019, the top statement here from the Annals of Gastroenterology, and I'll just read it. It says, there is no established consensus for the timing of subsequent surveillance, though most societies recommend yearly surveillance for HIV positive males and every 3 to 6 months for those with low or high grade AIN. There have been no prospective studies examining the time frame of follow-up, and given the variable nature of AIN development into anal cancer, it is difficult to form established standardized guidelines. So if you're struggling with it, the reality is everybody's struggling with it because we just don't have great standardized guidelines for what we're doing with this disease process. The bottom statement comes from my society, the American Society of Colon and Rectal Surgeons. And I'll just read this one. Screening with anal cytology, anal pap smear may be considered in high-risk populations as part of a comprehensive screening program, but the sensitivity and specificity of the test do not support its use for universal screening. And that again just kind of demonstrates that we don't have a great test. We don't have great guidelines. We don't have, well-established norms for us to follow or to fall back on as providers. And so this topic can be a little bit challenging in knowing how best to move forward. So having said that, let's talk about, well, what can we do? And then what's a reasonable thing to do for our patients? And I'll even give you some examples of what I do as I see a lot of these patients on a day-to-day basis. And I've been treating them for 15 or 20 years. And so I have some understanding of its progression and things to watch for. So we'll just take two examples. What do you do if you have a 34-year-old sexually active homosexual male who's well controlled with HIV in your office? And he asks, well, so about this AIN, what should I do? And he may not even have AIN, but he wants to be proactive about his health. What do you recommend for that individual? And on the flip side of that, let's say you have a 75-year-old heterosexual monogamous female who's only had one partner and been married all her life, who had a colonoscopy, and you find an AIN1 lesion. What do you do with that? And so let's talk about these different scenarios. One is a little bit more high risk, the other is lower risk, but one has the disease, one doesn't. and we can try to work our way through some of these challenges that we see on a regular basis. So as we talk about AIN, there's really three ways that we can screen individuals for this dysplasia. The first is an anal pap smear. And as we just read from the Society of American Colon and Rectal Surgeons, it's not a great test. And the reality is the studies that have been demonstrated show that it only identifies 59% of high-grade lesions. And so it's almost a flip of the coin. Like if you do the test and it comes back negative, that doesn't help you. And if it comes back positive, that's not always indicative that there's even visible disease. And so while anal pap smears are not wrong, you just need to understand that you may not be getting the information that you really are seeking. The other way to screen individuals is just with simple anoscopy. And so this is something that's just done in the office. You can insert the anoscope. You're looking around inside the anal canal and on the anal margin, trying to determine if there's any lesions. And that's a much easier test. It's very simple, but again, it doesn't always show the disease in a clear way, and so things can be missed. So you do need to have someone who has experience in doing this and know what they're looking for, which can be challenging because even for someone who has a lot of experience like myself, it's still sometimes not very easy to see these lesions. And I'll show some pictures and we can see why it can be a little bit challenging at times. The best way to really see if there's any changes is high resolution anoscopy. The problem is that it's a really expensive test to do. You need a lot of equipment. Usually you need to take individuals to the operating room or give them some sedation to do the test. And it's not feasible to screen, for example, 80 million people who have HPV when really it's just a very small number of individuals who are going to progress. So when do we employ this? Who are the best people? Again, just as we read before, we don't have great guidelines on all of these things. And so we do have to kind of fill our way through this process and look at each individual patient and make a determination on what's best for them. So just a few anatomic considerations before we get into some of these other screening modalities. As a proctologist, we look at the anus a little differently. We delineate the anal canal into two groups. The first is the anal margin. And so the easiest way to think about what is the anal margin is when you spread the cheeks apart, whatever you can see, that's the anal margin. Whatever you can't see up inside the anal canal is the anal canal. And so typically you need an anoscope in order to evaluate that tissue. And you can see that the anoderm there extends up to what we call the dentate line or the pectinate line. And that area is a zone of transition where the cells are changing from epithelial cells into mucosal type cells, squamous cells. And that's the area that you want to evaluate. And so, you can look on the outside, but that doesn't always tell you the whole story. And so those are the two areas of concern when we're evaluating for HPV and anal cancer. So this is a picture of what it looks like for high resolution anoscopy. You need a microscope, a special light. You place the anoscope inside, and then you start to look inside the anal canal as well as the anal margin. That's the first step. Then the next step would be to stain the tissue with 3% acetic acid, which then turns the tissue a white color, and it will kind of highlight areas of concern. Once that's done, you wash that off, and you can put some Lugol or iodine solution on the tissue, and that helps even further delineate the margins of the disease. And this is kind of what this disease looks like. So on the left, you can see clearly, well, there's a lesion, and that's very easy to see. But on the left side of this picture here, as you're looking, you can also see that whitish discoloration and a clear demarcation. I don't know if you can see my arrow, but here between the mucosal layer and the dentate line, and then this is kind of a whitish hue to it. And all of this tissue is bad. This is probably an AIN3 lesion, possibly a very early cancer. This is likely AIN1 or 2 that's starting to be highlighted with the acetic acid. On the picture on the right here, you can see they've highlighted an AIN3 lesion, but as you look at the rest of the tissue, it all looks very similar. And so down here is probably the same AIN2. It's a little bumpy and it's got some folds. However, this is smooth and shiny, and it looks much more normal. And so again, AIN can not always be very prominent, and it can be very difficult to miss. And that's the reason why high resolution anoscopy is kind of the best test to delineate the tissue and its appearance. But again, it's an expensive test. It requires a lot of time and effort, and it is not useful as a screening test for all patients. All right, well, now we've kind of talked about some of the challenges and what AIN looks like. The next question would be, well, how do we treat it? And there's 4 different ways that we would consider treating AIN. The first is with topical therapy, and we'll talk a little bit about the different modalities. You can also consider using infrared coagulation, which is an office treatment sometimes for hemorrhoids or other anal rectal complaints. The next one is incision and fulguration, so going in and surgically removing the tissue and burning it. And then last is vaccination, and we'll talk about what each of those offer in the treatment of AIN. So for all intents and purposes, the most 3 common topical treatments are 5-FU, which is a chemotherapy, cidofovir, which is an antiviral, and then Aldera, which is an immune modulator. And you can see there that they have different rates of success. The chemo and the immune modulator Aldera seem to be the best. They do demonstrate regression, if not complete resolution of the precancerous change. But they have high recurrence rates, and I think that's probably the biggest problem with these, is that you may use these treatments, but the tissue seems to, or the HPV and the dysplastic tissue will come back. And so close surveillance is necessary. These topical treatments, I do use them. Aldera is the one that I prefer. It seems to, at least for myself, work the best, but they're very difficult to put on. Usually you're treating people for months, 3 to 4 months. They put it on several times a week. The creams burn, and people just have a hard time tolerating them. So a 4-month treatment using this 3 times a week is a pretty painful process for most patients, and many of them just give up after a while. The other problem with the ointments is you're able to put it externally on the anal margin, but it doesn't always necessarily get the anal canal lesions. And so if you have a lot of disease within the anal canal, using Aldera isn't really going to make that much of a difference. And so you have to understand where is the disease, and then just the reality of using these topical treatments. So we'll talk quickly about just an infrared or laser treatment, which is an office-based treatment. It does decrease the morbidity. It's pretty easy to perform. However, it is not FDA approved for AIN, but there are many studies that are coming out showing that there is some benefit, and it does just coagulate or cauterize the tissue. And so if you can decrease the size or burn that area, a lot of times we'll see some regression of that. And so that is not an FDA approved treatment for AIN, but it is something that can be employed for minimal disease, especially in the anal canal. Lastly is our ablative treatments. And as a surgeon, this is one that I employ probably the most because I think it is the most successful. It really just involves taking someone to the operating room. We identify the tissue, we'll put acetic acid on it, and then we will excise and or fulgurate the tissue. And oftentimes I'm taking individuals who have multiple areas. It's just too much to try to treat with, an ointment. And so it is a very successful treatment in getting rid of the tissue at 80 to 100%, and the recurrence rate is oftentimes very low. However, just like with the other treatments, it is uncomfortable. We're cauterizing multiple spots within the anal canal or on the anal margin. This is a sensitive part of our body, and people do struggle for a week or more. Just recuperating, having bowel movements is problematic and painful. And so it's not the ideal approach, but it is a very successful approach and one that we do utilize quite a bit. Um, the the reality is probably the best approach is a combination of both. It's really looking at the number and the location of the lesions, and then trying to determine what's going to be the best for the patient in order to get a complete response and remove all of the diseased tissue. And most of the studies will demonstrate that a combination of both topical and ablative treatments are probably the best. And so we oftentimes will employ both to help in treating this disease. Lastly is HPV vaccination. And so this is hopefully going to change all of our lives as more and more of young people are getting vaccinated. And the vaccine has been out for 10, 15 years now. And so I really hope that we see a significant reduction in HPV associated cancers because of that. Um, the vaccine is approved for anyone under the age of 26, and most of the studies and most of the societies would tell you that the vaccine is not effective or recommended if you already have AIN disease. However, there was a Swedish trial that came out that showed that they did have significant regression of AIN and a lower recurrence rate if they vaccinated individuals who had AIN, especially in high risk categories like men who have sex with men. That study was repeated in part here by the National Institutes of Health, and they didn't find any benefit. And so right now it is not currently recommended. So those are that's the, I guess that's the standard. Anecdotally, I have been giving my patients vaccinations outside of these recommendations because I have a number of patients who have not responded well to any of our treatments. And I don't, the vaccines have done actually pretty well for some of my patients. We have seen regression of disease and we've seen a lower recurrence rate. So anecdotally, and again, this is not part of the guidelines, but just my own practice, I still use this for select individuals, and I have found it to be helpful in many cases, not in all cases. But for myself, when I have patients that aren't responding well to treatment, I just move forward with this, call it no harm, no foul. I don't think there's much risk in giving a vaccine to an individual. And it does seem to provide some benefit for some of them. So I think just to kind of summarize all of this, what is the best way when you have a patient with AIN to do, and how do we survey them? And the answer is nobody knows. And so again, the questions that were posed to us before was, what's the best thing to do with this? Well, we don't have great guidelines, and so your confusion is appropriate because we're still a little blind as far as what's the best way to proceed with these individuals. However, I thought that this statement from the Clinical Colorectal Surgical Journal was probably the most appropriate. And so I'll just read this. Patients who are followed closely with regular office visits every 3 to 12 months for a history and physical exam and standard anoscopy, so that's not the high resolution anoscopy, biopsy of any new or suspicious lesions, rarely progress to cancer regardless of the method used. The cost, value, and morbidity of high-resolution anoscopy should be further evaluated versus expected management. And I have found that to be very true in my own practice. As long as we are being vigilant and having people come back and keeping an eye on things, very rarely has anybody progressed to cancer. In fact, I've only had 2 patients in my 15 years that I know have progressed, despite the fact that we've been proactive about watching things. And so I think just to summarize, as you're sitting with a patient, you need to evaluate the risk to your patient. What are their risk factors? Are they HIV positive? Do they engage in anal receptive intercourse? Are they immunocompromised? If the answer is yes to those questions, those individuals are in a new risk category and you do need to watch them closely. If they do have a lesion, you need to determine what type of lesion, and if it's a low risk lesion, AIN1, and they have low risk factors, the reality is they will likely never progress to anal cancer. That doesn't mean we shouldn't treat them. That doesn't mean they shouldn't have surveillance, but they're in a much different risk category than other people. You do want to determine the number and the location of lesion. So is it in the anal margin? Is it on the outside, or is it up in the anal canal? Because that helps you determine how best to treat this, and then to choose your treatment option. If you have one small lesion, well, it's probably best just to remove it and then you're done. If you have multiple lesions on the anal margin, Aldera therapy may be the best. If you have multiple lesions in both the anal canal and on the anal margin, and surgery is going to be, extremely painful to heal, then a lot of times we'll start with the Aldera therapy and then we kind of move on. And then lastly, to offer surveillance. And again, the surveillance is determined based on the risk factors of both the individual and the AIN. And so for high-risk individuals who have AIN3, I'm watching them every 3 months in my office. They come in, we do anoscopy, we keep a close eye on things. If it's someone who has no risk factors or very few risk factors and they have an AIN1 lesion, I'll see them back in 6 months. I'll check them again at a year, and then we kind of let things go from there. And so just to kind of finalize, let's go back, so what do I do with a 34-year-old male who's HIV positive and sexually active? Well, this is someone that even without disease, I'm going to be a little bit more, I'm going to offer more close surveillance. And so if they have no disease, I would see them at least once a year and just do an anoscopic examination and make sure that we're not developing any lesions. Let's say they have or AIN3, then I would be seeing that individual every 3 months in the office, and we'd be monitoring things very closely. And I would be very aggressive with um, any surgical excision or fulguration, and using Aldera liberally to try to keep any disease at bay and keep things under control. For, let's say, a female with no risk factors and a low-grade lesion, well, I would remove the lesion or treat the lesion as appropriate, and then I would see them back in 3 to 6 months. I would make sure that there's been no recurrence of that lesion, and then I would offer them another surveillance anoscopy in the office in about a year, 6 months to a year, and we would just kind of monitor the situation. So um, in short, again, and I think the take-home message, there's a lot of people with HPV, 80 million it's estimated. Very few of them actually progress to cancer, but the ones that are going to are these high-risk cancers, and with the high-risk serotypes. And so those individuals should be much more aggressively monitored, because that's where it's those individuals you're going to get into trouble with. The other folks, they absolutely need to be treated, but their surveillance could be tailored and be less strenuous or aggressive. So anyway, I hope that's helpful. I'm happy to answer any questions that you have, and we can go from there.
Thank you so much. We do have questions. I was just about to interrupt you, but then I realized that we were ending. So first question is, for high-risk patients we see in primary care, who do we refer to for high-resolution endoscopy, GI? Do all GI providers do this?
That's a great question. I think that's one of the problems with high resolution anoscopy, is that there's not a lot of providers who do this. Colorectal surgeons should know how to do that. The OBGYNs do a lot of it, though I think that they try to stay far away from this side of the anatomy. I don't know of too many gastroenterologists, at least in our area, that do high resolution anoscopy. So there may be some where you practice, but by and large, it's going to be just the colorectal surgeons who oftentimes do it. But even then, they may not have the equipment. And so that's what I'm saying is it's a test that not a lot of people do because it's expensive and it's very time consuming. And so I do have that equipment here, but I actually rarely do it. I do a lot of anoscopies in the office, but that's because I feel very comfortable watching things. I've done this for a long time. And so, as a primary care provider, I would see you probably have to reach out to some surgeons to see who's willing to do this for you, and if anybody has the capability to do high resolution anoscopy.
I'm going to assume you just answered this, but I'm still going to ask it. Would you recommend we do endoscopy in primary care or refer to specialists?
It depends on how many you're doing. If you have a large population of, let's say, homosexual men who have AIN or who need screening, and you do a lot of it, I would say absolutely. I think a family practitioner can do it. You just need to have experience with it. If you don't feel like, you know what, I'm going to do this twice a year, then I would refer that on to somebody who's going to be more engaged or more used to doing the procedure and know what they're looking for.
Okay. Next question. How do you perform an anal pap, and would you recommend doing them with only 60% sensitivity?
So an anal pap smear is very much like a cervical pap smear. You just take the brush and you just insert it up inside the anal opening and take some cells and send it down. I do not perform anal pap smears because of just the numbers we talked about. It's, in my opinion, it's essentially worthless. If it comes back negative, that doesn't reassure me. And so I do a lot of anoscopy. That is my screening method of choice. It's very quick, it's easy. If I'm concerned about something, then I will set people up for high resolution anoscopy in the operating room. But I don't do anal pap smears for that reason. It's just I don't. It's just not a great test.
Um, how can we get trained in an anoscopy? Tongue tied.
Um, well, that's a great question. I don't know that there's any training courses. I think if you really want to do it, it is just doing it. If you have anoscopes in your office, you can start practicing. I guess that's just the best way. You just have to do it. It's, a digital rectal exam, lots of lube, and I use slotted anoscopes, and I will look at all four areas. So I break the anus up into quadrants, and we just look at each one. You do need to insert the anoscope up far enough so that you can see the dentate line. And so recognizing the anatomy, doing the procedure, it's a very simple thing to do. It just is practice. So as family practitioners, if you don't have a lot of people in your area, you may want to band together. And if somebody's interested in that, to send all of those patients to that individual so that they can get some practice and experience in just looking and performing the procedure. But if you don't feel comfortable, hopefully the surgeons in the area would feel comfortable doing that. But I will be honest, I have 7 general surgeons with me, and none of them are interested. And maybe that's because I'm here, but they just send everything to me, and so that's kind of how our practice has evolved. And so you'll have to look at what expertise you have in your region.
They all default to you. Just a reminder, you can put your questions in the Q&A chat box, use the raise hand feature while we're waiting for more questions. Reminder about the CME survey to make sure that you have the correct date and time, September 5th. No, not time. Date, September 5th. Speaker, Dr. Scott Nelson. I swear I know words. And that will appear when you close out of this webinar, so you can claim CME credit for that. You can also always submit your questions about this topic or any topic to our eConsult platform. So if you have some questions after this, or you can also request a video consult to talk through a scenario. I don't see any more questions, but we'll pause, we'll wait for any last minute. I mean, we have 20 minutes, so if you have questions, please feel free. All right. Oh. What are your thoughts about doing HPV testing with the anal pap?
Well, again, I think I don't have any problems doing anal pap smears. I think it's a very simple test to do, and I think it can be helpful. I think the key to remember is that a negative test doesn't reassure me that everything's okay. And so pap smears are fine. And if you feel comfortable doing that, it's certainly better than doing nothing. And so I would send those off. But if the test comes back negative, again, it's just not very reassuring that something's not going on. So I don't like it from a screening perspective because it has its sensitivity and specificity are so poor. But it's not, but it's better than nothing. And if it comes back positive, then that points you in a direction that this individual needs to be screened in a different way. So,
Thank you. All right. Well, I don't see any more questions. Thank you all for joining us today. Dr. Nelson, thank you for putting together a great presentation.
all right. Thanks for having me. Appreciate it. Have a great day.